កម្ពុជាព្រះរាជាណាចក្រអច្ឆរិយៈផ្ដល់ភីមកក់ក្ដៅ
ខ្លងឡ
កម្ពុជាព្រះរាជាណាចក្រអច្ឆរិយៈផ្ដល់ភីមកក់ក្ដៅ
ក Hi, hello everyone from Asia and all over the world. This is the 12th CPD Asia online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 12th CPD Asia is the Association of Cambodian Radiologic Technologists, ACRT. And I am Peachy Luna, your program host. We are again grateful to our sponsor, VT Healthcare, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search VART channel so you may join us live or watch again a replay using the YouTube of VART. This online CPD Asia is highly supported and graced by member societies, presidents, their officers, and representatives. Allow me to recognize them and let us greet and welcome President of Macau Radiologic Technologist Association, MRTA, Fernando Koch, President of Indonesian Society of Radiographers known as PARI, President Giek Sugianto.
Hello, good morning, everybody, everyone. Good morning, Pichi.
Good morning, dear President. President of Vietnam Association of Radiological Technologists, President Thai Van Loc.
Good morning, everybody. Good morning.
And we have also Ma'am Yin Yin Than of Myanmar Society of Medical Radiation Technologists. We also have President of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan Tu. President of Hong Kong Radiographers Association, President Wan Shu Buan Nelson.
Good morning, everyone, and Merry Christmas.
President of Singapore Society of Radiographers, SSR, President Denise Chung. We also have President of Philippine Association of Radiologic Technologies, President Rolando Benares. And I see many important people. Also, we have the former president of ACRT, President Sopheak-Radiological. Good morning to you. We also have the Vice President Jerry Lay of Macau Radiological Technologies Association and Chairman Danis Chin Chun Yu. We also have Putu Adisanta. We also have Sir Cheng Wu Lee. Good morning and Merry Christmas, everybody. So now let me continue, and to formally start the program, please welcome the ACRT Chairman, Mr. Kor Kim Sreng, and the ACRT President, Sophie Lee, for their opening speech and welcome remarks.
Hi, good morning.
Hopefully, you up one because you open a PC and smartphone together. I think you up one smartphone or PC. You play up one.
Can you Hi.
Yes, again, we'd like to call the ACRT Chairman, Mr. Kor Kim Sreng, and the ACRT President, Sophie Lee, for their opening speeches.
Good morning. Yes, welcome to the team. Yes, I would like to open and speak in my native languages. Maybe you can share later. Yes, first of all, we want to welcome all the distinguished guests, ladies and gentlemen. Chư thông khiêm bát số rục nhiều cái tiêu chiết nâng an trả chiết để bàn nâng chơi chô rùm toal nâng tam và bọt ẩm lạc để thấy nị ai có số rục đòl ai đóng lục chụp tiêu lục sấy sa sa cha chạm đất samachik samachika này samakum nè chạy tê với chủ sắc Cambodia này miền Bắc miền Phnom Penh chỉ tí bên tây ngày nay khi bật chỉ miền sẽ cái đây sau nó thì chẳng khăng đại ban chơi chô rum Phnom săn bạt nè chạy tê với chủ sắc Cambodia nâng sông Svakum hoặc lục sấy ai đom lục chụp tiêu lục sấy sa sa chán vì chém mình đất samachika này samakum nè chạy tiêu chụp sa Cambodia nông Cambodia maha săn bạt lực thì đập bấy bỏ samakum nè chạy tiêu với chụp sa Cambodia chạm năm vì bọn phình nguy nâng còng thịt bọt cá bật to áp phi quật chúng niên nè phải chạy tê với chủ sắc Cambodia đó miền sạ sục khăn đi liên trong cái này đại trong niềm nhung đầm nang ỏi rất rõ này sma cung nè chạy tê với chủ sắc Cambodia từng ngũ xôm sầm đại cả sma cung nâng cao xa đó cả cầm ca nâng samachika từng ở này sma cung dan miền sang cái phiêu này là trong cái riêng trong ở ban ở miền nơi TV Maha San Ban đi lại đi chia sna đại nâng chỉ là tập hall vui cùng ai cả sự quan hai cái team này đại có chia cả trong cả chụp chung và đôi chỉ cả bay chạy đồng lên nơi chụp này đăng nâng bắt đi sau là o này chạy thì với chú sa chun đoàn samachika nâng sẽ khai cam được không đại ban chùa rùm được cái đi hai bằng to chui sập sai nâng chạy đồng lên nơi chụp này đăng đại ban liên sốt nâng cái đi chun đoàn samachika bỏ dưa để chia để cho robot bằng pin phê cách tam thì pet nâng ăn phiêu điện này lời bên này từ tiết trong sớm play em nâng con đòn bên nam bên anh đã triệt đại ban là chơi chùa rùm nâng chạy đồng lên nâng pháp thoa nâng chụp này đăng lo tam mà chết này ca thua bật bằng hai tamประกวด online đại chùa rùm vì mình đã bật tê đôi chia bật Hồng Kông, Macau, Việt Nam, Myanmar, Taiwan, Indonesia,និង Philippines ដែលតែងតែចូលរួមចែករំលែកនៅបទពិសោធន៍ដល់សមាគមអ្នកបច្ចេកទេសវិទ្យាសាស្ត្រកម្ពុជាក្នុងបទបង្ហាញនៃអង្គសន្និបាតសមាគមអ្នកបច្ចេកទេសកម្ពុជាថ្ងៃនេះយើងសង្កេតហើយថាសប្តាហ៍នេះប្រព័ន្ធបច្ចេកវិទ្យាមានការរីកចម្រើនយ៉ាងឆាប់រហ័សមិនថាផ្នែកអាជីវកម្មនិងផ្នែកវិទ្យាសាស្ត្រដែលមានដូចជាម៉ាស៊ីនព្យាបាលជំងឺបារីម៉ាស៊ីន MRI ម៉ាស៊ីន CT scan ម៉ាស៊ីន angiography ម៉ាស៊ីនថតឆ្លុះដោយកាមេរ៉ាអីគឺសុទ្ធតែបើជាម៉ាស៊ីនដែលទំនើបនឹងប្រើវិទ្យាជាចុងក្រោយដើម្បីប្រកួតប្រជែងនៅលើទីផ្សារនិងដើម្បីដល់នឹងការធ្វើរោគវិនិច្ឆ័យយ៉ាងសុក្រិតជូនអ្នកជំងឺនិងគ្រូពេទ្យព្យាបាលគួរជាទីទុកចិត្តទន្ទឹមនឹងការរីកចម្រើននៅវិទ្យាវិទ្យានិងម៉ាស៊ីនទំនើបទាំងនេះបើសិនជាគ្មានធនធានមនុស្សដើម្បីទៅប្រើប្រាស់និងគ្រប់គ្រងម៉ាស៊ីនទាំងនោះទេនោះម៉ាស៊ីនទាំងនោះប្រៀបបានទៅនឹងដុំដែកមួយដែលគ្មានបានការចិត្តដែរដូច្នេះហើយទើបខ្ញុំសង្កេតឃើញថាបងប្អូនកូនក្មួយដែលជាអ្នកបច្ចេកទេសវិទ្យាសាស្ត្រទាំងអស់មិនត្រឹមតែអ្នកបញ្ជាម៉ាស៊ីនតែប៉ុណ្ណោះទេតែថែមទាំងដើរតួនាទីសំខាន់ ក្នុងការរោគវិនិច្ឆ័យក៏ដូចជាការព្យាបាលអ្នកជំងឺបានយ៉ាងមានប្រសិទ្ធភាពដោយការប្រើនៅចំណេះដឹងនិងជំនាញនានាដែលខ្លួនបានសិក្សារៀនសូត្រកន្លងមកនិងតាមរយៈសមត្ថភាពល្អក្នុងការប្រើប្រាស់និងគ្រប់គ្រងម៉ាស៊ីនទំនើបទាំងនោះផងជាពិសេសជាងនេះទៅទៀតក្នុងដំណាក់កាលដែលវិស័យនេះកំពុងមានការអភិវឌ្ឍយ៉ាងខ្លាំងនៅក្នុងប្រជាជាតិកម្ពុជាយើងក៏ដូចជានៅអន្តរជាតិខ្ញុំសូមសំណូមពរដល់បងប្អូននិងកូនក្មួយទាំងអស់គ្នាត្រូវផ្ដោតការយកចិត្តទុកដាក់ជាសំខាន់ទៅលើការពង្រឹងគុណភាពសមត្ថភាពនិងការពារកម្មវិធីជូនអ្នកជំងឺអ្នកធ្វើការជាមួយគ្នានិងប្រជាពលរដ្ឋទូទៅផងដែរក្នុងន័យបង្កើតនៅការប្រកួតប្រជែងនិងធានាឲ្យបាននិរន្តរភាពនៃដែលចេញពីការអភិវឌ្ឍលើវិស័យនេះជាក្នុងឱកាសនេះដែរដើម្បីរួមចំណែកក្នុងការអភិវឌ្ឍផ្នែកវិទ្យាសាស្ត្រនៅកម្ពុជាខ្ញុំសូមសំណូមពរដល់ក្រសួងសុខាភិបាលសាកលវិទ្យាល័យវិទ្យាសាស្ត្រសុខាភិបាលសមាគមវិទ្យាសាស្ត្រនិងរូបភាពវិទ្យាសាស្ត្រកម្ពុជាសមាគមអ្នកបច្ចេកទេសវិទ្យាសាស្ត្រកម្ពុជាព្រមទាំងក្រសួងឬស្ថាប័ននានាដែលជាប់ពាក់ព័ន្ធក៏ដូចជាសមាជិកានៃសមាគមទាំងអស់ពួតដៃគ្នាដើម្បីជួយជំរុញកំណើនធនធានមនុស្សនៃអ្នកបច្ចេកទេសវិទ្យាសាស្ត្រនេះឲ្យបានកាន់តែច្រើនប្រកបទៅដោយគុណភាពចំណេះដឹងព្រមទាំងការជំរុញផ្នែកវិទ្យាសាស្ត្រនៅកម្ពុជាយើងឲ្យកាន់តែរីកចម្រើនជឿនលឿនទៅមុខជាចុងចប់នេះខ្ញុំសូមស្វាគមន៍និងថ្លែងអំណរគុណជាថ្មីម្ដងទៀតព្រមទាំងជូនពរដល់ពិធីមហាសន្និបាតនេះប្រព្រឹត្តឡើងដោយភាពជោគជ័យនិងទទួលបានផ្លែផ្កាជាពីកប់ចិត្តជាពិសេសខ្ញុំសូមប្រសិទ្ធពរជ័យសិរីបវរជូនដល់អាយដាមលោកជំទាវលោកស្រីសាស្ត្រាចារ្យវិជ្ជាបណ្ឌិតព្រមទាំងសមាជិកាសមាគមអ្នកបច្ចេកទេសវិទ្យាសាស្ត្រកម្ពុជានិងសិក្ខាកាមទាំងអស់ដែលមានវត្តមាននៅថ្ងៃនេះសូមឲ្យជួបតែសេចក្តីសុខសេចក្តីចម្រើនព្រមទាំងជួបនៅពុទ្ធពរទាំង4ប្រការគឺអាយុវណ្ណៈសុខៈពលៈកបីគ្លៀងគ្លាឡើយ
Yes, may we call now President of ACRT, President Sophie Lee, for her message.
Thank you, Luna. Thank you for your support today. So, good morning, everyone, and good morning, all presidents. Thank you for your joining and participate today. So, my name is Sophia. I am a president of Association Cambodia Radiology Technology. Thank you for today, and thank you for all of you support our society today. And I'm really appreciate your help, and especially President Taiwan Lok, President Bunnin-Radioligical, and also Luna. Thank you for your support, and Merry Christmas. Thank you. Thank you so much.
So as we now continue to the most awaited part of the program, I'll be calling now Miss Anna to take charge of this session and introduce our distinguished speakers, presenters. Miss Anna.
Thank you for having me for today, Miss Luna, and good morning, everyone. And I'm talking from Cambodian, Phnom Penh, the capital city. So today is a very special day for our MU conference, and I'm very honored to have a special chance to be an MC on this program also. So let me introduce our special speaker. We have 3 speakers, and the first speaker is Mr. Phou Chilong. He is the radiological in Sunrise Japan Hospital, Phnom Penh. And the topics he is talking about the DWIBS. And the second speaker is Mr. Phou. He is an ACRT secretary, and he's also the radiological technology at Calmette Hospital, and he's also a teacher at Technical School for Medical Care. And the topic is about MRI stroke. And let me introduce the third speaker is Mrs. Loon Bunnin. She is a radiological technologist at Preah Mealea Hospital, and the topic is about head trauma. So the first one is welcome to our first speaker, Mr. Phou. Thank you.
Good evening, everyone. Good morning, everyone. Do you hear me? Sorry.
Yes.
Hello.
Yes.
Okay. Now I start my slide presentation, and I hope everyone gonna be well during COVID-19 pandemic. Okay, today I will presentation about the DWIBS that we can call diffusion vertex image or body background with the background signal suppression. Anyone can see my slide?
See, okay. We continue.
Today's agenda is first introduction and overview. Second is comparison of DWIBS and PET-CT scan. Third is potential application of DWIBS in oncology. 4, DWI protocol. And 5, comparison between the DWIBS and PET-CT scan image. What is DWIBS? DWIBS is an alternative to PET-CT scan for visualizing the lesion throughout the body, supporting the role of MRI in oncology study. DWIBS suppresses the normal organ tissue, blood, muscle, and fat to achieve the high contrast between the background and the lesion that use the MRI to for the cancer and metastasis across a wide area of the body. The inspection method is an inspection method developed by Japan people. From 2019, we use the last image technology DWIBS methods by MRI in Central Japan Hospital for the search of cancer and search for metastasis to high-risk cancer patients. DWIBS for the very first in Cambodia. We are actively providing an advanced medical care in our hospital. And here is comparison between DWIBS and PET-CT scan. Comparison to PET-CT, which perform a similar whole body cancer test. PET-CT focus on the high energy metabolism, sugar metabolism of the malignant tumor. Cancer, we're searching for the malignant tumor. DWIBS focus on the fact that malignant tumor has a high cell density, narrow between cells, and search for the malignant tumor based on the water movement between the cells. And here is the comparison table of DWIBS and PET-CT scan. For the DWIBS exposure, no, but PET-CT scan, we use the both exposure to inject table and radiation. For the injection, no, but PET-CT scan, we use the intravenous injection for the test drug. Food restriction, no, But for the PET scan, we use the pre-test fasting and insulin restriction. For examination of DWIBS, about 30 minutes or 40 minutes, but for the PET scan, around 3 hours, including injection.
Sorry,
Yes,
sorry. You please share again, because in very small, everybody cannot see in your big presentation PPT. Mr. Tong, you guide for you information for him. You guide for him.
You are using the recenter. That you recenter display. Please change to the presentation display.
Display, sorry.
Using full screen. Okay, you show again. You show your presentation again.
Okay, please.
Yes. Okay. You to the display setting in the top left of screen.
Display setting.
The display setting in the top left of screen.
Sorry, sir.
Display setting. Display setting.
Yeah.
We have three tools in the top left of screen. So taskbar, display setting, and slideshow. You see the top left of the screen of
yes,
your presentation.
Yeah.
Change display setting.
Yeah, display setting and then.
Duplicate text slideshow. Okay. Okay, it's okay.
Yes, good. Yes.
You can continue.
Okay, please. Is it okay?
Change display setting again.
Oh.
Yes. You can continue. Continue to speak. It's okay.
Okay.
It's okay.
Yeah. For the post-test treatment for DWIBS, no. But for the PET CT scan, the patient had to wait until the radioactive drop. For the diabetes patient, inspectable, but for the PET CT scan, maybe not inspected. And here is the comparison of the cancer diagnosis of DWIBS and PET CT scan. And we separate the optional, possible, unavoidable, and impossible. Number one is lung. DWIBS is possible, and PET CT scan is optional. Number two, colon. DWIBS is optional, and PET CT scan optional. Number three, stomach. DWIBS possible, and PET CT scan unavoidable. Number four, for the pancreas, DWIBS possible, and PET CT scan optional. Number five, liver, DWIBS possible, and PET CT scan possible. Number six, gallbladder and bile ducts, DWIBS possible, and PET CT scan unavoidable. Number seven, breast, DWI is optional, and PET CT scan optional. Number eight, malignancy lymphoma, DWI and PET CT scan is optional. Number nine, prostate, DWIBS optional, and PET CT scan possible. For number 10, esophagus, DWIBS possible, PET CT scan unavoidable. For leukemia, impossible, and bladder, DWIBS possible, and PET CT scan impossible. And this table I screenshot from the from this link that I put below the table. And practical improvement of DWIBS we separate two, good and very good. For the brain, neck and shoulder, very good. Chest, very good. Abdominal, pelvis, liver, pancreas, and spleen, very good. For the colon, very good. For the kidney, very good. Uterus and bladder, good. Prostate, good. And extremity, good. Oh, very good, sorry. And here is the protocol management of the DWIBS that we do in Sunrise Japan Hospital. We separate the four part of the DWIBS. That the first part we cover from the pocolusum to the shoulder, and the second part we cover from the shoulder to the low liver region, and the third part we cover from the liver to the pelvis, and the fourth part we cover from the pelvis to the both thigh. And of this additional protocol, we add the coronary 1 and coronary 2. If we finding the other lesion, we will add more protocol depend on the location of the lesion. And here is the DWIBS image that was performed in Sunrise Japan Hospital. And here is the reformat image. And second one is the coronary 2 image. And third one is coronary 1 image. Other diseases detected by the DWIBS. For the cerebrum, such as the sinusitis or retention, you can detect it also. For the cervical spine, you can detect it such as the cervical lymphadenopathy or something. Thyroid is also thyroid. For the lung, you can detect the lung nodal or lung tumor also. And the liver, you can detect the liver hemangioma or something. And here is the comparison between the DWIBS and PET scan image. You can see the blue color, the circle of the blue color, that DWIBS can detect the tumor the same the PET scan. And the lower part of the femur, PET scan cannot detect it, such as the red color. And thank you so much for your pay attention. If you have any question, you can ask me by my Gmail. Thank you.
Thank you for your very good speech, Mr. Pujilong. And hope everybody get a new and good experience and also good idea, and it's helpful for your compassion. So I would like to welcome to our second speaker is Mr. Phou Sopheak.
Okay, xong chuẩn bị xuống cho room and the first I would like to say thank you for everybody that give us the chance for the presentation and help and support us. And good morning everybody. Today I have the presentation would like to share with you, talk about the MRI stroke. So maybe I share the screen, and if my slide is not good for looking, please let me know. Okay, now can you see my slide that I share? I share already. Okay, now for the MRI stroke, yes, the first I would like to introduce myself. My name is Sopheak. I'm a General Secretary of the ACRT. And I'm also the Radiology Technologist in Calmette Hospital and also the lecturer part-time at the University of Health and Science for the radiographer in Cambodia. So I just talk two points is what is the stroke and purpose of the MRI protocol for the stroke patient. Okay, the stroke is the brain attack. So the stroke can cause a lot of cause that make to have the stroke. Like we have like stress, depression, and we have a lot of work and we headache also. So we have a different type of the stroke. One is the ischemic stroke, and the second is hemorrhagic stroke, and the third is the transient ischemic attacks that we use the TIA. So the ischemic stroke is the blockade of the vessel, the blood vessel, and let us the blood flow to the affected area. That means that ischemic stroke is the some of the blood flow have a problem, like have the stenosis or some of the blockade that not allows the blood to feed the brain tissue very well. So it can cause a lot of problem like ischemic or lacuna. And how about the hemorrhagic stroke? The hemorrhagic stroke is the rupture of the blood vessel, leakage of the blood in the affected area also. So we can make a different type of the stroke. Yeah, so this one is the stroke that we separate to the two kinds of the stroke. Is the blockade of the blood vessel that we call the ischemia or cerebral infarction, or lacuna and thrombosis and embolism. And the second is rupture of the blood vessel can cause like cerebral hemorrhage and subarachnoid hemorrhage. Okay, so for the detect of the stroke, we can use the MRI, and we also have the basic protocol for the MRI for detect the stroke. The first is the important one is the DWI, that means diffusion vertic imaging. And
sorry, Sophia.
Yeah,
sorry,
yeah.
Sophia. You please stop share and share again, and then Mr. Tong tell for you how share again. You please stop share.
Stop share?
Yes, stop share because you in your slide you not move. You please stop share and you share again.
Okay, I will.
That screen again.
Yes, sorry.
Mr. Tong.
Stop share. Sorry.
Mr. Tong.
Okay. Please move to the first slide.
Okay, stop share and then I can share again, right?
Yes.
Share, and then I have to go to the. Now, can you see my slide?
Yes.
Smaller, bigger. Smaller slide.
Okay, move to your first slide and show again.
This one?
Yes.
Okay. So now you see clearly, right? Okay, so sorry for.
So your recent. Move to your first slide and show again.
Oh, okay.
Yeah, show again.
Okay,
please wait.
Okay, so sorry.
Not yet.
No, please wait. Your slide it don't move.
Now it move.
Yeah, yeah. Okay. Click again. Click again. Click again.
Oh, like display.
Please close your PPT software and open again.
Okay, so sorry.
Maybe the PowerPoint product activation failed.
Yes.
Okay, and I will open my slide again. So sorry. Okay. Sorry, I can find my share slide. I cannot see it. Okay, I see now. I will share again. Now you can see my slide.
So again. Yes, yes. No.
Okay, now you can see.
Oh no.
You look the right below. You can click and right below.
Right below.
Okay, good.
Now you can see.
It's okay. It's okay.
Yes, okay.
Okay.
You can
Let's continue. Let's continue.
continue and
Okay.
yeah, you move.
So I'm not talking. I have to start again or just talk, continue with my slide. Okay, I will talk again. So sorry for my a little bit trouble. And I would like to talk about the MRI stroke and have two kinds of this, my content. The first is what is a stroke, and the second is the purpose of the MRI protocol. Yes, the first I would like to talk what is the stroke. So the stroke is the brain attack. Yeah, that can cause a lot of reason, like we have depression, we have a headache or something. Yeah. And we different type of the stroke, we have three. The first is the ischemic stroke, and the second is the hemorrhagic stroke, and the third is the transient ischemic stroke that we call the TIA. Yes, the blockade of the blood vessel, lacks of the blood flow to the affected area, we call it ischemic stroke. And the hemorrhagic stroke is the rupture of the blood vessel and the leakage of the blood in the affected area. So different type of the stroke is the stroke we separate to two kinds. One is the blockade of the stroke vessel, and it can cause the cerebral infection and can have the lacuna infection, thrombosis, and embolism. And the second is the rupture of the blood vessel, can cause through the cerebral hemorrhage and subarachnoid hemorrhage. So this is the basic protocol of the MRI for detect the stroke. The first column is the basic protocol that useful for the MRI for the detect the stroke. So the first is the DWI, diffusion vertic image, and second is the flare, flip attenuated IR, and third is the B-phase that we use the biphasic parallel anatomic screening. Yeah, and for the MOA we use for the vessel or the brain. we use the MRA of the head and MRA of the neck. So for the additional protocol for MRI, we have a T2 vertic image, and we have T2 star vertic image and T1 vertic image. And we also have the special one is the ASL, the arterial spine label. So the basic MRI, we use the diffusion vertic image and flare attenuation, fleet attenuation image, and T2 vertic image and T2 star vertic image and T1 vertic image. So this is the image of the MRI that show for the first column is the flare, and the second is the DWI, and the third is the T2 vertic image, and the third is the T2 star and T2 and T1 vertic image. So this is the image of the MRI that can be detected. So for the basic also, we use the MRA of the head and neck. We have like looking for the vessel without contrast. So this is the image of the angiography. We use the without contrast. We use the MRA angiography. So this is the COW, cycle of the village of the brain. So this is so that we have if we have the rupture and blockage of the vessel, we will see on this also. And this one is the next MRA. So this is the basic also. We use the biphasic parallel anatomic scanning. We use the heavy T2 vertic image designed with the visual line of the surface of the apparent of the vertebrobasilar artery without the cistern. So the plan of the scanning is here. We put the plan parallel to the basilar vertebrobasilar artery. We can see the image like the right side in here in the image B. Yeah, we see the vessel of the basilar artery on the brain. Yes. Yes, now we talk about the clinical of the imaging for the MRI detect for the stroke. For this one, we use the cerebral infection acute phase within 1 day. So in 1 day, for the cerebral infection with the MRA, we see the left side, we saw the image of MRA cycle of the belief. We saw the blockade, of the blood vessel in the right side. So it can caused by the embolism. And the second image is the thrombosis that have the small vessel like a stenosis and thrombosis that can cause the blood to supply to the brain tissue is not very well. And DWI for the lacunas, we saw the hypersignal in the right side of the ventricle. So this one is also the cerebral infection, acute phase within 1 week. So for the flare imaging, we saw in the left side of the ventricle, saw the hypersignal like that. And for the T2 vertic image, we also saw the hypersignal also. And the left side, we saw at the right side of the ventricle and the temporal loop, yes, of the brain also. Yeah, and here is the cerebral hemorrhage basic protocol. We use the flare at the first image and also saw the flare in the second image also, and MRA. Yeah, the first is the rupture of the vessel. So we have like the hemorrhage at the right side of the ventricle, at the left side of the ventricle, and the rupture of the aneurysm. We saw the hemorrhage, yeah, Mealea. Okay, and we see the 3D MRA, we see the rupture, and we see the aneurysm of the vessel. This is the table that show the stat and the time, and we use with the T1 vertic image and T2 vertic image. Yeah, here is the stat like a hyper acute. Yeah, so the hemoglobin is shown in the T1 vertic image is iso signal, and T2 vertic image is a high signal. That means the brain have the problem less than 12 hours. So for this one, this acute for the deoxyhemoglobin red blood cell. So in the T1 vertic image is iso signal, and T2 vertic image is the low signal. That means it's occur 1 to 3 days. So this is the state of the brain attack, or is this so the state of the ischemic. Yes, and we use to study it with the T1 vertic image and T2 vertic image and T2 star. Yes, the image below, the first is the T1 vertic image, and the second is the T2 vertic image, and the third is the T2 star. So like we have a problem with the blood rupture, yeah, like have the clot like that. So this is the cerebral hemorrhage. The cerebral hemorrhage, dissection, cerebral aneurysm. We have 3 kinds of the cerebral hemorrhage like that. In the image, it is hemorrhage, yeah, inside the lumen of the blood vessel, and this is the hemorrhage outside, yeah, outside the blood vessel, like in the tube also. And we use this one. We use the BFAS, yeah, basilar parallel artery cerebellar. Yeah, we see the like the aneurysm on the blood vessel and the basilar blood vessel here. And this one we saw the occlusion of the cerebral infection in here in the arrow points in the cerebellum also. Okay, now we talk about the special protocol for the MRI. Is the ASL. So the ASL is the arterial spine label. We use this one to suppression, like we use the ASL for focus on the penumbra area. So the penumbra is the area that around the staying around the ischemic death or the dead tissue or the brain. So we use the imaging with the slab label, and then we do the subtraction. We will see the good image of the ASL. Yeah. So what is the penumbra area? The penumbra area is the area that around the dead tissue of the blockade or ischemic lesion of the brain. So the penumbra is the white color in here. Like this one is the infection tissue. That means the brain tissue is there. So the penumbra is the area surrounding that. So the white color is the penumbra, and the green color is the normal tissue. So the penumbra is useful for detect that which tissue that can survive or can secure from the medicine, or from we use the thrombectomy or we use the syringe. So DWI perfusion mismatch. That means we combine together with the perfusion vertic image with the diffusion vertic image. And so we can show the green area is the penumbra area in here. Yeah. So we combine DWI with brain perfusion. Yeah, with the brain perfusion. This is useful for detect that which area is the penumbra and which areas can we survive, or can we restore back to the normal tissue. And this one is the MOA on the brain cycle of the belief. We saw the loss of the West cells to supply the brain tissue in the left side. Yes. So how we can restore the brain tissue from the stroke? So how to refute perfusion? What if we detect the stroke is less than 2 or 5, it's less than 4 to 5 hours, we can use the IV medicine to inject to the intravenous to survive the brain tissue. We use the TPA, tissue plasminogen activator. On second, we can use the endovascular treatment within the 8 hours. So the Penumbra system will be used in this system, in this treatment. And also we use standard retriever to retrieve the clots or the blood blockade from the vessel. So how do we know that we have a stroke, or how can we detect we have a stroke? So we have 6 words that easy to remember. We use the BFAST. BFAST, B is for the balance. That means the loss of the balance or headache or dizziness. We will the sign of the stroke also. And the second is the blur. The E for the eye. If we blur, it's difficult to look or difficult to see. It's so that we also have the sign of the stroke. And F for the face. One side of the face is dropping down, left side or right side is dropping. A for arm or leg weakness, yes. As for speak, it's difficult to speak or difficult to talk or difficult to speak also. And T is the time to call for the ambulance immediately if we have the other sign, like we have the B sign, E sign, F sign, A sign, or F sign. We have to call to the emergency, to the ambulance. The time is the tissue or the cerebral it's important. So if the time for longer, that means the brain tissue is died a lot. So if we have quick, we can survive a lot for the brain tissue. Okay, so this is the MRI protocol for the stroke. We can separate into also. We have the blockade of the blood vessel, and we have a rupture of the blood vessel. So we have a cerebral infection, and like we can cause the lacuna infection, thrombosis, and embolism. And we have the other one is the rupture of the blood vessel and can cause the cerebral hemorrhage and subarachnoid hemorrhage. Okay, thank you for your attention, and my slide is this end. And if you have a question, you can chat and we can talk later after the finish the slide presentation of the speaker. Okay, thank you so much. Thank you.
Thank you, speakers. For now, we will be having a 15-minute break time, and as we resume later, we shall be having our last speaker and the Q&A session. So meanwhile, you can type your questions in the Q&A chat box. Thank you.
ពុជាព្រះរាជាណាចក្រអច្ឆរិយៈផ្ដល់ភីមកក់ក្ដៅ ព្រះរាជាណាចក្រអច្ឆរិយៈផ្ដល់ភីមកក់ក្ដៅ ព្រះរាជាណាចក្រអាឆរិយាផ្ដល់ភីមកក់ក្ដៅ
Welcome back, everyone. And now may I call again Miss Anna to introduce our last speaker. Anna?
Thank you. So, let us continue. Everybody hear me? Thank you. So let's move to our third speaker. And please welcome to Mrs. Loon Bunnin. The topic is head trauma.
Okay, good morning, everyone. Thank you, Miss Anna. Good morning, everyone. Good morning, all professor, and good morning, especially all the member of ACRT. Okay, today is such my honor today to having a speech. So my topic today is head trauma management. So, okay, let's start. Okay, so my topic today is head trauma management. Let's get started. So the content today is we're talking about the definition, cause of head trauma, and the type of head trauma, and the next is investigation, pathology, complication, and diagnosis study, and then management, and then preventive measure, and the last is rehabilitation. So first one, we're talking about the definition of head trauma. So head injury is any degree of traumatic brain injury that ranging from skull laceration to the LOC. So LOC, it means loss of consciousness, for neurologists, the defeat. Okay, so traumatic brain injury encompasses a broad range of pathologic injury to the brain of varying clinical severity that result from the head trauma. So any head injury and traumatic brain injury are often used interchange. So the causes of head injury is from motor vehicle accidents, falling down, partial or spot-related injury, and sometimes it's from firearm-related injury. So it is a high potential for poor outcome that occur at 3 points in this after injury. They divide into 3, it immediately after the injury, and then between the 2 hours after the injury, and then the next is 3 weeks after the injury. So next is the type of head injury. So for head injury, it divides into 4 parts. The first one is skull laceration, and the next is skull fracture, and the third is minor head trauma. And for minor head trauma, it also divides into 2 syndromes as well. The first one is concussion, and the next is post-concussion. So the 4 for head injury part is the major head trauma is the last point. It's divided into 2 as well. It has cerebral contusion and laceration. So we will talking about the skull laceration first. It is the most minor type for head trauma, and the skull is highly vascular, produce of bleeding, and it is major complicated, is infectious. The next second point is a fracture. It located of fracture alter the presentation of the magnificent, and it visualize the location of fracture, a small fracture, and sometimes fracture at the fascial bone, and also the neck is fascial paralysis and conjunctive of deviation of gas. And sometimes the patient will get the battle sign and raccoon eyes. And then here is the picture of the battle sign and the raccoon eyes. For the battle sign is caused by a type of serious head injury, or we can call it basal fracture. And the type of fracture it almost occur at the base of the skull, like behind your ear or the nasal cavity, like this. And the picture of raccoon eye is here. It refers to the bruise around the both eye and look like the dark punch around the eyes. And the signal is a serious condition from the skull of head injury as well. So for the vascular skull fracture in the cerebrospinal fluid leg extravasation into ear, sometimes like oral hair or nose, and it called no hairs. It is a high-risk infection to meningitis. It also some show of halo shine on close of linear, and it possible injury to internal carotid artery or permanently CFF legs that we call cerebral spinal fluid is like possible as well. So the third one is about minor of head trauma. We talk about the first one first because we divide into two parts. We have concussion syndrome and the post-concussion. So for the concussion syndrome is a head injury with temporary loss of a brain function concussion that can cause a variety physical, cognitive, and emotional symptoms. It comes from the sudden acceleration and this acceleration injury. Example from car accident, sport injury, or bicycle accident. And for the post-concussion syndrome, it's almost shown on after 2 weeks or 2 months after the injury, and then persistent headache, lethargies, or personality and behavior change. Lethargy is in here. It means the patient will feel lack of energy and sometimes have too much severe headache. And then next we move to the measure of head trauma. It including two as well. It have cerebral contusion and laceration. And both injury represented a severe trauma to the brain. And here the image of the cerebral contusion that you can see. The hemo is brighter, and here is the laceration of the cerebral. So the next is a major head trauma that we're talking about a contusion. It's the bruising of brain tissue within a focal area that maintain the integrity of the perimeter and also arachnoid layer that associated with multiple microhemorrhage and small vessel bleeding into brain tissues. And about the laceration, it involves a acute tearing of the brain tissue, intracerebral hemorrhage, and it also is generally associated with cerebral laceration. Okay, and then we are talking about investigation. For investigation, we have CT, MRI, and for the CT is this should be the first line of the investigation in case of any head trauma. And for CT scan, it visualized to see more detail of skull fracture, bleeding, or swelling in the brain. And if you have a sign of a serious injury, a CT is usually the best first test to diagnosis. And for MRI also we can use for investigation as well. But MRI can detect a variety of conditions of the brain. Sometimes we can see cysts, tumor, bleeding, or swallowing, the developmental or the structural abnormality of the brain, the infection, inflammation, or the condition. And also the problem with the blood vessel, we can see in the MRI scan. And bleeding from the ear or nose in case of suspected CSF leaks, we call halo or sign or ring signs when dubbed on the tissue paper. For the pathologies, in here we divide into two. The first we have extra-axial hemorrhage, and the second we have intra-axial hemorrhage. So for the intra-hemorrhage, we have epidural hemorrhage and subdural hemorrhage, or we call acute chronic. And the third is subarachnoid hemorrhage. And the intra-axial hemorrhage, we have 2 points as well. We have intraparenchymal hemorrhage and intraventricular hemorrhage. And here is the friend hematoma anatomy. We have epidural, intracerebral hematoma here, and the subdural hematoma. So for the epidural hematoma, it is the result from bleeding between the dura and the inner surface of the scalp. And most commonly, type of this trauma, intracranial bleeding, it rarely occurs spontaneously. It is a neurological emergency or commonly bleeding by arterial origin breaking to the middle of the minor artery. And here is the CT scan of head image. On the CT here is we can see the cloud is brighter by the bicoctic subcloud, and it will define border. It will define border usually respect in the cranial suture lines. And here is the type of brain hemorrhage that I just talking about at the previous slide. We have one is epidural hematoma, and the second is subdural hematoma, and the third is subarachnoid hemorrhage, and the fourth is intracerebral hemorrhage. Okay, so we're talking about clinical manifestation. The patient will internally unconscious after the trauma, and then the person then awakeness and has a lucid interval followed by the decrease in LOC, mean loss of consciousness. It means loss of consciousness, and sometimes headache and nausea and vomiting. So we were talking about the subdural hematoma. It occurs from the bleeding between the dura mater and arachnoid layer of the mantle cell covering of the brain. In this subdural hematoma, it usually results from venous bleeding and usually from the tearing of the breathing vein running from the cerebral cortex to the dura sinus. If this hematoma may be slowly to develop. So for subdural hematoma, it also divides into 3 types as well. The first one is called acute subdural hematoma, and the second is subacute subdural hematoma, and the last is chronic subdural hematoma. So we are talking about acute subdural hematoma. It overdeveloped 24 to 48 hours after the severe head injury. and it commonly related to the acceleration or deceleration injury. The clinic manifestation are the same as intracranial hematoma. The size of the hematoma is determined the patient clinical presented. It means that the size we can determine the patient size by seeing the image of the CT scan here, and it's also make the patient decrease of LOC from dozy or confused to unconsciousness and headache and Phillips and lateral pupil dilation as well. And also sometimes it's motor sign. On this CT scan head here, we can see the cloud is brighter or mixed color or mixed density and degree and crescent shape. It crescent shape maybe have a left distinct border. Okay, then next we go to subacute dural hematoma. It usually occurs within 2 or 14 days after the injury, and the alteration in mental status as the hematoma development. Its progression depends on the size and location of the hematoma. Okay, and the last is chronic subdural hematoma. It develops over 2 or months after seeing minor head injury. The peak incidence of chronic SDX, means subdural hematoma, is in the year of age 50 to 60 years. The classification is a progressive alteration in make the person lose of consciousness. And here is some image of anatomy of the hematoma. It divides as epidural hematoma and subdural hematoma. And here is talking about epidural and subdural as well, but it just do the table that we easily to see about the location, the involved vessel or the symptom and the CT appearance. In here for epidural, we can it always location between the skull and the dura. But for the subdural, it always happen between the dura and the arachnoid. And involved vessel is for epidural, it's temporal parietal most likely, and the middle of minor artery frontal and anterior iliac artery and occipital or transfer or at the immersionis. But for the subdural, it involves only the breathing of the brain. And the symptom is for epidural is losing interval followed by the unconsciousness, and subdural is gradually increasing headache and confusing. And for the CT appearance, like I showed you as the previous slide, for epidural is in the big length and limited by the suture lines of the brain. And the subdural is appearance in the crescent shape and across the suture lines. Okay, and the last is intrahemorrhage, ICH. Intracerebral hemorrhage is hemorrhage that occur within the brain tissue itself. It divides into main types as well. The first one is intraparenchymal hemorrhage. It intended into the brain parenchyma. And the next is the second is intraventricular hemorrhage that it's intended into the ventricle of the brain. And the causes is hypertensive vasculopathy. It around 70 to 80%, and sometimes caused by the rupture of the aneurysm and the head trauma. And then next we go to complication after the head trauma. complication after the head trauma. Here we have neurological defection or death. So in here it means the neurological defect here it means refer to the abnormal function of the body area, that this alter function is due to injury of the brain or spinal cord or nerve. Example like the patient with abnormal reflex or unable to speak. And the next is seizure. The next one is obstructive hydrocephalus. And the next is spasticity. In here, it means the patient with abnormal muscle. Abnormal muscle, it means it feels tightness due to a prolonged muscle or contraction. And then the next is aspirate. It is a complication with the aspiration pneumonia, and then causing ochlea, and the neuropathic pains. The neuropathic pain in here is mean a pain that the condition of pain that usually chronic, and it usually caused by the chronic progressive nerve disease, and it can also occur as the result of head injury or infections. And the next is deep venous thrombosis, and the next one is a pulmonary embolysis, and the last is sometimes cerebral hemorrhage. And the next is we're talking about the diagnosis study for the head trauma patient. If we have a CT scan is considered the best diagnosis test to evaluate for craniocerebral trauma because it allows rapidly diagnosis and intervention in the setting. It also can recognize the type of bleeding, swelling, or the skull fracture. Okay. And especially CT is we can save the time for the patient because it might more faster than doing an MRI or an X-ray. For head CT and cervical CT scan it should be required to perform in the same time for this case of patient for head injury. And the GSS, it means GCS score, it means the glaucoma score. It should be less than 15 after the ban of head injury. It warrants a patient with no intoxication consideration of it must consideration with the urgent CT scan. The glaucoma score here, it normal rank is limit 15. So the patient, the doctor will examine the patient if they lose of they have less than 15, they must bring the patient to do the urgent CT scan first to know the diagnosis of the patient. Okay, and then next is talking about the MRI. MRI is for diagnosis study as well. It's more sensitive than the CT scan and detect small lesion for demonstrating the size of acute subdural hematoma, and also the cerebral angiogram. If the hemorrhage is confirmed, but it's not necessary in case of classic hypertension hemorrhage patient. So and then the last we can do also the transcranial Doppler, allow the measuring of the cerebral blood flow. For this transcranial Doppler, it's a non-invasive ultrasound study that is used to measure the cerebral blood flow velocity in the measure of intracranial artery. And then we go to the management. Management here we have supportive measurement. The first, we need to prepare everything and bring the patient to do the exam as priority. In here, it means we must be prepare everything. It means we must be done in the safety room. We prepare for the machine. We prepare for we prepare everything for the patient come and do as much as fast as possible to do the exam for the patient. And then we need to prepare emergency aid in case of patient with severe condition. We prepare emergency aid like we should have a compressed oxygen or oxygen tip, or we could have a patient monitor to know about the patient pulse or the oxygen of the patient. And the next is the nurse and D, it means medicine doctor must be standby in case with the patient with a severe condition and prepare medicine as needed in case of the patient with severe condition as well. And the evaluate head of the patient from 20 to 30 degrees is needed. It avoid of any next one compression. Here is we have preventive measure. It have promotion, prevent car. The patient must prevent car accident and or motorcycle accident. And to wear safety helmet is needed. And for driving a car should be have a belt, a safety belt as well. And annual health checkup in case of the person that they know that they have a high hyper blood pressures. In case that they don't know what the blood pressure of they must be checked annually. So the last is taking care of elderly person from accident falling down. Okay, and then the last is we're talking about the rehabilitation. Rehabilitation here is really important for improve the ability of function of the patient that they can do at home or their community to help treat the mental and physical problem caused by after the head trauma. We have ambulatory and home care. Nutrition here is really important as well for the patient to recover from the head injury. Need to check for the bowel and bladder management and specificity. And also dyspnea. Dyspnea, the patient will have a problem of swelling or swelling with certain food or liquid. And other sign is sometimes they are coughing or choking while eating or drinking. And these are disorder. And also family participation and education is needed as well. And here's my time. Okay, so that's all for my presentation.
Yes, thank you very much. We now welcome back our speakers and panelists. We will now accommodate to answer the interesting questions from our participants. So meanwhile, I'd like to ask all our speakers, presenters to please check also the chat box, the Q&A chat box, for the questions that were typed in by our dear participants here. And again, we welcome back our presidents and representatives, officers from different associations in Southeast Asia and Asia. So we can help here read questions from the Q&A chat box. All right, so I guess I have to read the first question here. Although some were clearly discussed by our dear speakers here, I'd like to read one question from an anonymous attendee. So to our dear speakers, for the MRI stroke patient, is it a mandatory choice even without a doctor's request in Cambodia?
Okay, thank you for the good question. The first, I would like to thank you to Mr. Sushi Nofina that gave me the good question. Talk about MRI stroke patient is the modality choice for even the without the doctor request. So I would like to say that if we suspect the patient have the stroke, for the MRA of the MRI, we usually do for detect the abnormality of the vessel or the brain vessel or the carotid vessel. Okay, this is important to detect that we have stenosis or have the embolysis, like I saw in the slide. Like I have a little bit show again a little bit for the slide yet. So it is very important like this slide, like this by the right image like that. So it is the most important. However, without the doctor request, if we suspect the patient have the stroke, we have to do it the MRA for the patient. Yeah, thank you.
Yes, thank you very much, Mr. Sopheak-4. We have another question here, and this is for our second speaker. Oh,
Yeah.
to Sir 4.
Yeah.
For brain MRI, how do you give the difference between embolism and thrombosis infarction?
Okay.
With your brain MRI.
Okay, thank you, Mr. Sang, for your good question. Yeah, between the thrombolism and embolism, we know already the thrombolism or the stroke can caused by the blood vessel clots that in the artery going through the brain. So it's created by caused by the blood clots. And for the embolism, is the stroke occur when the clot get former and anywhere like a snot in the brain, like sometimes from the heart, from the lung, or from the other everywhere, and go through to the bloodstream, travel from into the bloodstream, and clots also go to the brain also. So it have the clot anywhere and then go to the bloodstream, go to the brain. So we can recognize that which one is the thrombolism and which one is the embolism. So I would like to show a little bit slide about this one. I will say a little bit and talk about the thrombo and most of the thrombolism, like a stroke that cause the embolism, it's have effect area like the dead tissue is very smaller than the embolism. The embolism that means the total of the brain was like this image. This is the this thrombosis, cerebral infection. So the effect area or lesion is not large, it's not huge like embolism. So we can recognize by the MRI like this. If we saw like we have the ischemic stroke very big, so we suspect that this is the cause from the embolism. And if we saw the lesion like a part by part, like para-ventricle, less ventricle, right ventricle, but the smaller, like the dot point. So we suspect that it is the thrombolism, cerebral infection in the MRI imaging. Yeah, okay, thank you.
Yeah, before I call Mr. Lu Tridong, let me read the third question here to our third presenter speaker. How do you, to our third speaker, there's a question in the chat box that goes for you. How do you evaluate the severity and subdural hematoma by CT scanning without checking patient conditions? to our third speaker.
Yes, thank you
Yeah.
for your question. So, hello. Yes, thank you for your.
Sorry, you up some smartphone or PC around you.
Okay, thank you for your question. We can see for subdural hematoma by we can see in the I will show you my slides. But we can easily to modify in here. We can to modify between the epidural and the subdural hematoma. It have the 4 points here. We can modify by the location for the between for the subdural. It will location between the dura of the arachnoid of the brain, and it involved with the vascular with breathing of the vein, and the we will correlate with the symptom of the patient as well. We can ask the patient with the patient will gradually increasing of headache, and sometimes they are confusion, and also they will confusion after their head trauma, and we will see in the CT scan is the crazy sub across the suture line as well, that we can modify of the subdural hematoma. We can make sure with the patient as well to clarify of the subdural. Yeah, especially and also especially with the history of the patient. Thank you.
Yeah. Thank you for that question that came from Miss participant Seng. Now, a follow-up question to you, Ma'am Lun. This is from Hilarius from Indonesia. He's asking about people with meningitis. Can the flare MRI technique be used? And please, your answer, Miss Lun Bonin.
I'm sorry.
Is this for first speaker, Miss? So before you answer, I can also call Lu Trai Du. There's a raised hand here. Do you have a question, Lu Trai Du?
Yes, thank you, Bichi Luna. Firstly, thank you for your valuable presentation of Mr. Paul Sophia. And I would like to a small question to you about the MRI for stroke. You know, it's important to cerebral stroke at a time. Yeah, time very important. But MRIs can time usually to relatively long, especially for patients with brain stimulation who cannot lie still, usually to move a little bit or a lot. So very difficult to perform the technique. So can you give your experience to show this problem? Can get a short-term time to take MRI and get a good imaging for patient. Thank you. Thank you very much.
Okay, thank you for your good question. Yeah, I would like to answer the question. If the patient cannot cooperate very well and cannot stay still in the MRI machine, so the first choice is we can use the CT scan, brain CT scan, to detect that it has ischemic or it has a hemorrhage. So the MRI just spend a little bit, maybe 1 minute. Yeah, if we do the CT scan, the CT scan, and we saw the hemorrhage, so everything is finished. And if we do the CT scan or the brain, and we saw that we don't have hemorrhage or we don't have the lesion or ischemic, so the MRI still be the best choice for detect the early stage of the ischemic stroke or the stroke brain attack. So my question is have two choice. The first, if the patient is not cooperate well, we can do the CT scan first for the brain for detect that the patient have the bleeding or not, or have the like a ischemic or not. And this is the still cannot be detected by the CT scan. So we can do the MRI, but the MRI we just use just a basic, and we use the emergency MRI. We just use the DWI, that it is the good sequence for the detect the early of the stroke. Yeah, this one. And the second just do the flare, because the flare we can also saw the lesion or the ischemic stroke or bleeding stroke in the MRI also. So we just use like a 2 sequence or 3 sequence of the MRI for the quick scanning. Yes, for the MRI to detect the stroke. Okay, my answer like have just only two kind like this. Okay, thank you.
Yes, another hand was raised, this time by the Vice President of MRTA, Sir Jerry Lay.
Then this also in Macau also have a question.
Jerry from Macau. I have a question for Mr. Sopheak.
Yeah.
Yes. I just a simple question. I just want to ask about if a patient has been diagnosed with a stroke through a CT scan or MRI in your clinic or your hospital, will the patient be sent to do the interventional treatment right away, or you will do some other things else to help him or her? Thank you.
Okay, thank you for your Mr. Cherry Lee. Yeah, and for this one, if we detect that is the patient have a stroke in the MRI imaging, we send them to the neurosurgeon to the radiology interventional. If the patient have like a ischemic stroke, we do the like a thrombectomy for or for help the blood flow. We do the thrombectomy. This one we do by the radiology interventional, that nowadays in our hospital, Calmette Hospital in Cambodia, we also do with the angiography thrombectomy. Yeah, and we also if we saw that the patient have the problem with the hemorrhage, we can do the interventional radiology also. We do with embolism. Yeah, we use the embolism to stop the bleeding. Yeah, we do with the radiology interventional also. And for the early stage of the stroke, we can use the like I saw in my slide already. We have 2 kinds of the treatment. One is we inject the TPA. Yeah, that is the first step that can help a lot. So less than 5 hours, that means the stroke that have less than 5 hours, we can help a lot. Yeah, if more than 5 hours, like a 10 or 1 day or 2 days or 3 days, I think it's not helpful for the treatment or the stroke patient, because everything is gone, like the tissue or the brain, it's died already. So we have 2 kinds. One is that we inject the TPA, and the second we use the radiology interventional, like thrombectomy or embolization. Yeah, thank you.
Yes, we would like to know if there are still additional information that our panelists would like to add on here.
They need to Macau.
Oh, yes.
Yes, thank you.
Yes, Chairman Dennis Chin.
I have one question for Mr. Polk also.
Yeah.
Thank you. You talk about MR protocol stroke. I wonder if CT stroke protocol will be performed first when suspect stroke patient is sent to your hospital clinic. Thank you.
Sorry again, Mr. Chen Chin-yu.
Yes, I wonder if the CT stroke patient will be performed first.
Yeah.
When suspect stroke patient is sent to your hospital.
Okay, yes. For the CT, if we suspect the stroke patient, we send to the in the hospital. We have a neurology department. We have the interventional radiology department. So if we saw or we detect that the patient have the stroke, we will alert to the neurologist, yeah, to the doctor that by the phone first, because it is emergency. So we will know that okay, it is the ischemic stroke. So they will use and we can by the aspect score, we can assessment that the stroke is can survive or cannot survive, like that. So if the stroke is can survive, we will call emergency to the neurology surgeon or to the neurology doctor. Will be informed that your patient have the stroke or have the bleeding in the brain, so they can help the patient a lot. Yes, like that in my hospital nowadays.
Okay,
meet your question. Okay, thank you.
All right, so I guess that would be all. In the interest of time, we have to cut from here to give way for the closing session. But may I humbly request first our speakers and our panelists, presidents, to please open your camera for the photo session.
Camera photo section.
Okay. One more. And last one. All right. Thank you very much. So again, we would like to say thank you to our speakers, Mr. Phou Chilong from the Sunrise Japan Hospital, Phnom Penh, to speaker, former President for Sopheak of Calmette Hospital, and also the Secretary General of ACRT, and also to our third speaker, Ms. Lun Bunnin of the Preah Mealea Hospital. Again, thank you so much, our dear distinguished speakers and presenters, and to our panelists. We have learned so much from your interesting and important discussions. In closing, I know everybody's excited to know about the next CPD Asia schedule and to address invitation and to tell us more about this exciting event. Let us welcome, on behalf of President of TAMRT, Chun Yu-Won-Tu, please welcome the Director of Taiwan Association of Medical Radiation Technologists, Cheng Wei Li.
Yeah,
okay, thank you.
Thank you.
And thank you for all speakers for their presentation. Due to the affairs of the association, President Du is not able to attend this meeting. So on behalf of TAMRT, I am happy to announce that the 30th CPD conference will hosted by Taiwan on January 15, 2022 at 2 p.m. local time. So there are 5 speakers will share their clinical study and experience. So we are look forward your attending and see you go online again. Merry Christmas. Thank you.
Wow, sounds interesting. The first CPD Asia in year 2022 will be this January. So now again, let me call the Association of the Cambodian Radiologic Technologists Association, President Sophie Lee, with her final message. Yes, President Sophie Lee would like, yes.
Okay, do you hear me? It's okay. Okay, again, I'm really thank you for everyone to support today, even to be successfully, and we are from the Association Cambodia. Thank you for all president and donor for support the program from the beginning and until we smoothly finish the event. So on behalf of ACRT Cambodia, we are really appreciate and for the Mr. Thai Van Lok and all the president in Asia that always support Cambodia and always share the knowledge and try to connect and keep in touch with us. So the last, I thank you for all speakers today and for all speakers that provide a good topic and lead the program to be successfully. And the last, and say Merry Christmas and Happy New Year. Thank you, Luna, and thank you, everyone. Have a good day. Thank you so much.
You will, you will, microphone.
Wow, thank you. And we congratulate the Association of Cambodian Radiologic Technologists, ACRT, President Sophie Lee, all your officers and the organizing committees of the 12th Asia CPD. We thank also the support of our sponsor, VT Healthcare Vietnam. And most of all, we are sincerely grateful to all the member societies, presidents, to our hardworking CPD Asia IT team, and to the many registered participants who have made this online CPD Asia program a success. We would like to see you in the 13th online CPD Asia in January 2022. Again, I am Peachy Luna and I say thank you everyone. Have a great weekend.
Thank you, Luna. Thank you so much. See you.
Everyone. You're welcome, Pichi Luna.
Thank you.
Merry Christmas.
Thank you, everyone.
Merry Christmas.
Merry Christmas.
All of you.
New Year.
Merry Christmas. Goodbye.
Thank you, Pichi. Thank you, Lok.
Yeah, thank you.
Thank you,
So,
everyone.
yeah. I
Thank
can
you, Lok. Thank you,
open
PG.
the pages.
Thank you, Sir
Thank you,
Daniel.
everybody.
Bye
Bye.
bye.
See you.
Thank you, VT Healthcare.
Thank you so much.